Hi, and good evening, and welcome to Maternity Midwifery Hour. It's Series 17, it's Session 9, and my name's Sue Macdonald, and I'm the curator for the Maternity Midwifery Hour and the Maternity Midwifery Festivals. And it's my pleasure just to be presenting this evening, this session. It's going to be slightly different because I've had to pre-record this because I'm not able to be with you. Next week we'll be back to normal. And I'd just like to say a big welcome to those of you who are new and those old friends who join us every week in a very loyal and lovely way and ask all those lovely questions. Tonight we don't have any opportunity for questions and answers, so you'll need to hold them in for next week. And I've just got a little snippets of news. One, if you haven't already, check out the International Confederation of Midwives petition for 1 million midwives. And do sign the petition if you'd like to. That's on the resources this evening, so that'll be very useful. Sadly, we won't have a whole million midwives in the UK, but this is for the whole world, and it's really important. There is an international shortage of midwives all over, so we need to really highlight how much we need midwives and what strength and value we have. It's also this week, it's World Diabetes Day on the 14th of November, and the Academy of Fabulous Stuff are doing some insights. They're doing a little podcast. So that's also on your resources list. So have a look at that. Now you'll notice this week's a little bit different. I'm in my little usual place, but I won't be on Wednesday. So that's why I'm here tonight recording. There's been two big events this week, and that's the Midwifery Education and the Student Experience Festivals, both on the Wednesday, both at Leicester de Montfort University, and also available online. And we wanted to give the Maternity and Midwifery Hour participants a little flavour of what the festivals are like if you can't get to see them. Because I know that a lot of our guests and our participants are from all over the world, and travelling is not necessarily very practical for you all. So there's, as I said earlier, no question and answer session this evening, but two lovely presenters presenting their work, which would be really interesting. And the first of the sessions, making up the Maternity and Midwifery Hour, is from Nicky Clark, who you will all know as a very dedicated midwife educationalist. She's was the chair of the Nursing Midwifery Council Lead Midwifery Education Strategic Reference Group, a very active stakeholder group for midwifery education. So she knows midwifery education in and out in the UK. She's also a nurse and midwife and has been in midwifery education since 1990, working in lots of different institutions. And when she was at University of Hull, she did a lot of work, not just in the UK, but also in the rest of the world, including Europe and Asia. And she provided a lot of expert advice for educators in different countries on especially approvals for programs, which is a very important part of educationalist life. It's getting things to a certain standard and getting them through and approved, and also looking at institutional quality assurance across the UK and Croatia as well. She's also a senior fellow of the Higher Education Academy, and she's now in a kind of different lease of life as a freelance educationist, and she has been and continues to be actively involved at strategic level and with national developments. And she's extremely passionate, and you'll see from her discussion this evening, very passionate about midwifery education, particularly, and totally committed to ensuring quality and excellence in the education of all those who experience it. And this is very timely because some of you in the UK will have heard some of the about the feature in one of the national newspapers, suggesting that midwives and student midwives are being taught too much about the ideology, I can't even say it, of normal birth, and that's what the teachers are teaching and what midwives are doing. And when you're in the profession, you kind of know that's not quite how it is. We teach about physiology of normal birth, we teach about physiology, the whole of physiology, but it's not with any, stop. If there's a problem, we need to deal with it, and we need to work with a multidisciplinary team to give that high quality care to mothers and babies and families. So this is very timely, and I'm sure you're going to enjoy Nicky's presentation because she's always very passionate and interesting to listen to. Our second presentation is improving patient safety in maternity through immersive simulation technology. And this is from Angela Ayuk, who's a very strong professional with demonstrated history of working in maternity care, clinical research, and the charity retail industry. She's also skilled in midwifery, project management, research delivery, and Microsoft Excel and payroll and all sorts. And she graduated from Oxford Brookes University. So enjoy the sessions and really immerse yourself in what our speakers have to say. And remember, one of the things we value and about the Maternity and Midwifery Forum is everything's recorded. So if you enjoy this session, I'm sure you will, share it with your colleagues and have a discussion about it, because you might have some questions at the end of the session which you haven't been able to ask. So there's often people in your group, in your family of midwives, who will know some more information and can share with you. And it gets the discussion, gets it into your brain as learning, really quite useful. Now, next week, just to highlight, we will be back to normal, and the hour will be focused on, now I'm going to have problems with this one, glucokinase hyperglycemia, rethinking gestational diabetes. And this is very timely. We're focusing on the lived midwifery experience of implementing genetic testing within the existing gestational diabetes care pathway to ensure consistency and equity of access. And we have Nicola Young, who's a midwife and project lead, who's from the North East and Yorkshire Genomic Medicine Service. And do remember, all the sessions that we have, you'll be able to find more about our speakers online. So do have a look on those later. In the meantime, enjoy the session this evening and take care of yourselves, and I'll see you next week. Take care.
So I am going to look at the Midwifery Education Overview. Now, excuse me, I have talked extensively about a lot of issues regarding midwifery education, so I'm not going to repeat a lot of that, and I have only got 15 minutes, so I will obviously condense it. Now, I've actually put it into three main issues that I'm going to talk about. I have written an article that you'll find on the MMF website, really, that's related to these three issues, just to sort of explain a little bit more. Now, this is very topical. I've had this in, I've mentioned it quite a few times, and it's about the rise in caesarean section rate. I am not saying it is a bad thing. I will say that all three of my children were born by caesarean section. However, I did try. I was induced for 2 days. Luckily, they did pelvimetry then. I have a small pelvis, and so apparently, believe it or not, my inlet is too small, and so I would have died. So all I can say is caesarean section has its place. It is absolutely important, and it is life-saving. What I will say is that we have seen a trend. And the trend is that this is a rise in caesarean section rate, and for many units, I believe it's tipping over the 50%, sometimes higher. Now, when we used to talk about normal childbirth, and I have been in midwifery for some time, and it was talked as normal childbirth. And the reason it was normal is because it was the usual, typical, and expected birth. That's what normal means. The majority presents. So if the majority present, that makes it normal. So therefore, if caesarean section rate is now outstripping spontaneous vaginal birth, is this a new normal? So it's just something that, to think about. This is where we're going. When we looked at midwives attending women in childbirth, that is our protected function and title, is that we care for labouring women during childbirth. If it is a planned caesarean section, there is no labour. That's okay. There is no labour, so therefore is a midwife going to be there? It's a fear, and I'm just putting it, but there is a potential. And actually now, for the intrapartum stage, arguably more doctors than midwives are attending women at birth. When you're looking at staffing, and staffing in maternity units uses different tools to look at it. many use the birth rate plus, and they look at the birth rate plus rate, which is births to midwives, and that's anticipating that midwives are attending these women in childbirth. If that's not going to be the case, this is going to actually alter the number of midwives on the labour ward and arguably the skill mix. Student midwives still need 40 births. Where 40 came from, we've had this discussion. I'm not even going to go into that today. But it has been 40 for some time. It is an accepted number, and it is in the ICM and obviously in the NMC proficiencies and standards. So 40 spontaneous vaginal births for student midwives are getting increasingly difficult for student midwives to achieve. And as LMEs, I used to work at Hull as LME. As LMEs, we used to sort of discuss at length the 30-20 option that is there in the standards. That's not an easy option, because that's actually 50 spontaneous vaginal births that student midwives have to see. If they're not going to see that many because of the rise in cesarean section rate, because if 50% plus are caesareans, then you have the instrumental, the instrumental births on top. And it's looking at, are we going to have student midwives extending the programme, and so therefore reducing student numbers in the long term. This could lead to a problem just going forward. I'm just raising it. So that is an impact on pre-registration programmes. The thought of reducing the number of births that a student has to have has been thrown around and talked about. But do we feel that students are confident and competent after 40? This is where the discussion rises, why 40? But if we feel that there is still some question mark if somebody is competent and confident after 40, would we want to reduce that? And if so, by how many? All of these are absolutely profound discussions that need to have, because the impact is actually significant. And I've also brought in the role of the midwife, obviously with intrapartum care, but also I have to put in postnatal care and preconception care and contraception. This is all things that midwives did, and yet very few actually still do this. And we need to look at our role and our scope of practice, because it seems to be disappearing. My second issue is variation in student learning and assessment. We know that students need support for them to be confident and competent. A lot of changes happened when everything moved from a national programme to approved education institutions. And that's when it all became a degree-only profession, and more universities are coming on board. There was quite only a few at first, but now there's more and more coming on board. The thing with that is every university has its own nuances, it has its own regulations, it has its own processes. And all of these actually have an impact, which I'm going to come on to for my next slide. But we also devolved assessment of practice to practice. That happens sometimes. And arguably, those who are doing practice, are the ones in the right place to assess students' confidence and competence. But then we look at how prepared and how able are student midwives when there's discussions around the short-staffed units, the vacancies, the pressures and the complexities that actually are taking midwives away from student learning, because they tend to, quite rightly, women, to ensure women are safe. And so therefore, where is the student in this? And of course, we need to ensure that these students have a robust assessment, because they're the ones that you will rely on as a colleague once they qualify. And they need to be obviously at a stage that you feel that they can do this. And what we're hearing is that students are not feeling ready. They're not feeling confident. They're not feeling competent. And that is a concern. If we're looking at different universities, and this is no criticism of universities, it is the system as is. But there are variables. So if we look at programme length of, say, both programmes, the long programme, minimum of 3 years is the standard. Doesn't say anything more than that. It used to say 3 years, 45 programmed weeks. It was really quite explicit. Some programmes are 4 years. Some programmes are slightly longer than 3 years, in between 3 and 4 years. So if you have a 4-year programme compared to a 3-year programme, that's an extra year of where students are being supported and nurtured, as opposed to a 3 years. And when the new proficiencies came in, as an LME group, we did fight quite hard to make it a standard for a 4-year programme, because we felt what it needed because of what was included additionally in the new standards. KPMG conducted a survey, and students and practice partners voted against a 3-year. For all the obvious reasons. One is cost, but 2 is that they would take 4 years to get a midwife as opposed to 3. If you're looking at assessment tariff, again, universities for a 20 credit module have varying assessments from 1,000 words to 4,000 words. You know, to a Viva of 20 minutes to an exam of 3 hours. It varies, but depending on the regulations and the assessment tariffs. Now, that is quite a big difference of what students can be assessed on, and also the robustness of the assessment. I'm not saying any assessment isn't robust. Please, I'm just talking about the variances. The staff-student ratio in universities, again, the standard was 1 to 10. 1 midwife teacher to 10 student midwives. Nursing was 1 to 12, health visiting was 1 to 15. That hasn't been the case for many years, certainly since 2009 standards, and there is now a variance across the UK. We've done this as a trawl, and also the RCM looked at the staff-student ratio with their freedom of information calls, and the variance can be as wide as 1 to 11, 1 to 12, to 1 to 38. So again, if you're looking at a teaching team that has 38 students to 1 midwife teacher as opposed to 11 to 1 in another, which students are going to feel more supported? How much more can you devote time and to visit clinical areas? That's a big difference. Again, units who have different staffing, they do brilliantly well, and I'm not saying that their students are any less of a midwife, but I'm trying to talk about the variations here. The interpretation of the standards, I can't recall how many discussions we've had about how you interpret the standards. Yeah, please come in. And obviously we're looking at things like hours, practice breaks, all of those sorts of things. 50-50 split pretty much. Some universities count practice breaks, some universities don't. That is actually quite a lot of hours that some universities are asking or not asking their students to have. And this is quite irritating for some students. I used to get criticisms saying that I'm paying for childcare and I'm paying for travel and all this for the extra weeks that students in university not far from us don't have to do. And I would try and say, but you are having the 40 hours. We'll try to divulge as to how, or dig deep as to where this came from. And I'm not unconvinced it wasn't from the short programme, because nearly every university did the short programme. Short programme students were employed, and if you're employed, midwives aren't paid for breaks, and so it carried on. And I think that's where it's sort of come from, and it's obviously crossed over to all programmes. Proficiency sign-off and preparation of our midwives for assessment and supervision varies. Standard is appropriate preparation. What's appropriate to me might not be appropriate to you or to anybody else. It's appropriate, so it's not regulated anymore, so therefore it's not approved by the regulator, and it's certainly not monitored. And so I feel that there is a disparity as to how some midwives are prepared and some midwives are prepared in different places. And then, of course, we've got staffing in units and we've got cultures, and that's all with the reports. So what we need is our newly qualified at the same level. Because what I'm hearing and what I was hearing was that our preceptorship programmes were different for different people. They had the standardised preceptorship programme, but when they looked at their newly qualified groups, they realised that some midwives were at different places to others, and they were therefore having to tailor their preceptorship programmes or extend it. That shouldn't be the case. in my view. You know, a newly qualified is a newly qualified midwife. And so it's just something that needs to be considered. Quality assurance, again, I've talked extensively about this. Profound changes, I say, since we moved into universities, and changes in regulator. There is a variation, I've just explained, with student learning, assessment and experience. Obviously, programme approval and monitoring, and as an assurance of quality is that the approval and monitoring process is issued to another provider, which is now the Quality Assurance Agency. It is looking at the standards. So the root of everything is the standards. So if you are adhering to the standards, then it will be approved. But as I've tried to sort of explain, the standards can be interpreted differently. So you're still adhering to the standard, so you can't, you know, say you're not adhering to the standard, it's just being interpreted differently. And of course the monitoring. Now the NMC look at, because I've obviously talked to the NMC at length about the standards and the ambiguity when they've been party to a lot of our discussions. And they adopt what they call an outcomes focused approach, as opposed to process driven, which is what we had before. So outcomes focus means this is the outcome we want. How you get there, you use the standards to get to that outcome. And therefore, it's open to interpretation. You're allowed to have interpretation. You're allowed to have flexibility. But is this causing confusion for students? Is it causing confusion for the clinical staff? Because if they have students from different universities that do things in a slightly different way, we have standardised the assessment document. It's quite cumbersome, but there's a lot of proficiencies to include in that. And we did, of course, change the assessment, the supervision standards, and many went online, all during COVID. It was a little bit of a perfect storm. So I still think we are reeling from that. And then, of course, universities, is well documented, are in financial crisis. And that's largely due to lack of international students, European students, and the exchange, and research. Because the researchers are predominantly collaborating with European universities, and the uncertainty of the funding and the future of researchers, they have left and gone back to their respective countries, taking the funding with them. And this has caused a problem. And so we know that there are swathes of redundancies across healthcare programmes. From personal experience, it's usually the higher tier because you are the most expensive. And they are recruited, and then you recruit a lower band because they're cheaper. We used to have within the process standards exactly what you needed to become a midwife teacher. And you had to have a certain number of years experience, you had to have done your professional programme, which is the advanced diploma, and your teacher training in one of 5 institutions that was approved by the EMB as was then, before you could apply to be a midwife teacher. That is not the case. And it is actually many junior midwives, and I'd say the teaching staff are brilliant and they work so hard and tirelessly and do as much as they possibly can, but they haven't got the experience, many, or the expertise that you had to have or demonstrate previously. And there is no time limit. And experienced midwives are reluctant to take up lecturer posts because it's such a salary drop. It does not align with the agenda for change. It does compare unfavourably, and therefore it's a problem because we can't recruit experienced midwives. When I started, it was a big salary hike, very different. And then partnership working, which is critical. This is a 50-50 programme. Theory is assessed in universities, practice is assessed in practice. We have to work together. And yet, when I go back to the staff-student ratio, there are problems because if you have somebody that, because if you have a high staff-student ratio, there is very little slack in the system. So if someone's unwell or something happens for some reason, and you were due to go in practice, you would cancel a practice visit because you would teach a classroom of students, quite rightly, because they've come in for a session. And it's usually the first thing to go, whereas before it was actually in the standards that we had 20% of your time as a midwife lecturer spent in clinical practice. And so it was there, safeguarded. It couldn't be forsaken because you had to do it. So we need change. I'm talking about the rise in cesarean section and its consequences for staffing. There is, of course, the issue of the microbiome for the neonate, nature designed babies to come that way because of the bacteria. I'm not sure if this will happen, something at a later date, but it's an interesting prospect posed to me by someone who is very interested in that sort of thing. Obviously, looking at the midwife's role, statutory principles, we need statutory principles and processes to be put in place to safeguard the quality and consistency of programme delivery. And where and how students learn now assessed must be revisited. We need to have a consistent approach. We need to produce confident, competent, educated midwives that remain in a profession they are supported and equipped to be in. So that is my sort of parting, if you like, hope that we want. So, thank you.
Good afternoon. I'm sorry we were unable to be with you today, but we're really pleased that we have the opportunity to share our work with you. My name's Angela Ayuk, and I'm the Fetal Wellbeing Lead Midwife at Northumbria Healthcare. I work closely with Alison Bommel, our Practice Development Midwife. Last year, to build resilience within our training team, Alison and I collaborated to deliver all the mandatory maternity training for our maternity staff. We were fortunate to gain access to a new immersive simulation suite, and this provided a fantastic opportunity to enhance the quality and the impact of our training. Using this facility, we've been able to integrate immersive simulation into our training. This allows participants to practice clinical scenarios in a safe, high-fidelity environment, helping to build confidence and strengthen skills. So what is immersive simulation? Well, Health Education England defines this as a learning experience that uses technology and realistic environments to immerse participants in clinical scenarios, enabling them to experience, respond and reflect as if they were in real practice. And what about the standards that are set nationally for maternity simulation training? The core competency framework provides the clearest guidance. It outlines key training content that should be covered and sets a minimum standard that 90% of all staff groups should complete training each year. It also states that at least one simulation should take place within the clinical area. However, there is no prescriptive national standard that defines what maternity simulation should look like. We recognise there is variation nationally in maternity simulation training, and that this is very dependent on local resources and capabilities. While simulation in the clinical area provides realism, it can be challenging due to workload, space and staff availability. Research suggests that the use of immersive simulation can significantly increase learner engagement, motivation and performance. However, there is currently limited evidence to support improvement in patient outcomes. At the beginning of our project, we evaluated the current training environment shown in the slide. Although we used simulation, the environment and equipment was unfamiliar and did not mirror our maternity setting. Staff often reported that they felt awkward in the role play and talked through what they would do as opposed to actually carrying out the clinical care. There was no clock to acknowledge the passage of time, no telephone or emergency buzzer to practice escalation, and no means to digitally document using our maternity electronic system. We also did not incorporate any fetal monitoring sounds, images, or equipment.
This is a short video from an emergency skills scenario to demonstrate what training looks like now. The scenario starts within the home environment. This includes realistic background noises such as TV and hoovering. Touch-sensitive walls activate fetal heart sounds. In the front of the screen, you can see midwives documenting on the digital patient record. Documentation is cast on the wall for everyone to review. SimMum can also communicate and respond through remote audio. There's a complication at home and the woman is transferred to the maternity unit. The environment now replicates one of our birthing centre rooms, with authentic background noise to ensure familiarity and realism. Fetal heart CTG images are visible, and this supports practice of critical decision making in real time. Staff can use touch-sensitive wall icons to practice escalation through an emergency buzzer and telephone. A clock is visible, and as the scenario progresses, the clock updates to acknowledge the passage of time. A call is put out for an emergency, and you can then see the team working together in real time to deliver IV fluids, drugs, and manoeuvres. Documentation continues throughout the emergency. The woman is then transferred to theatre, and again, this replicates our actual maternity theatre environment.
Debrief following immersive simulation provides the opportunity to review care in real time and identify what went well and gaps in practice to drive patient safety. Smaller group sizes have been introduced to foster a psychologically safe environment in which staff are encouraged to share experiences and suggest improvements. Bullet points and images are displayed on the wall to support discussion and learning. Staff are also asked to complete digital feedback at the end of each session. Since starting the project in January, we have trained over 300 staff using the new immersive technology, and feedback so far has been extremely positive. Over 90% of staff surveyed who participated in emergency skills or fetal wellbeing training felt comfortable with the style of learning. 96% of staff who participated in emergency skills training felt they learned something new, and 91% of staff who attended fetal wellbeing training said the immersive suite enhanced their learning. Here are a few examples of feedback from staff. Themes from comments included: training is better compared to previous years. Staff commented that they felt more engaged, more focused, more comfortable, and more motivated to engage in simulation. Training was also noted to be more valuable and enjoyable. In terms of positive outcomes, following staff feedback from debrief and review of care during simulation, we've introduced several practical changes within the clinical environment to enhance safety and support teamwork. Examples include new digital clocks above the beds to help staff monitor the passage of time during emergencies, introduction of a new quick reference handbook specifically for obstetrics. This is a concise, accessible manual containing emergency algorithms to guide staff. Review of digital documentation following simulation also identified personalised care, risk assessment, and SBAR as areas for improvement. Additional training has been put in place to improve documentation in these areas. We've also been very fortunate to gain charity funding for training equipment that mirrors the clinical area. For example, a new red emergency trolley is now in place, and we are also now sourcing a home birth bag. We are also delighted that this year our project was shortlisted for a HSJ Patient Safety Award in 2 categories, and we have also recently been informed that we've been shortlisted for the RCM Educator of the Year Award. Of course, there are and there have been challenges. As early adopters of the technology within our trust, we have had to invest a lot of time to understand not only the capabilities of the technology, but continuously refine and improve the simulations week by week. We also needed support from our management team, as delivering this training would not be possible without increased resource within the training faculty. 2 members of faculty are required to effectively run the simulation, and delivering the training in smaller groups meant increased resource to deliver more sessions throughout the year. There is also the challenge of measuring patient safety improvement. It's difficult to pinpoint how much of a change in clinical outcomes comes directly from training. especially when one training day can touch on so many different aspects of care. So, in summary, local staff feedback and research suggests that there are clear benefits of using immersive simulation with increased learner engagement, motivation, and enjoyment. What is less clear is how improvements in patient safety and clinical outcomes can be measured. On a local level, we recognise that we are still in the early stages of our project. Our focus is on maintaining momentum by actively seeking feedback and being responsive to continually refine our training. We have recently placed a bid to further upgrade our SimMum mannequin for a smoother, more realistic training experience, and we are also exploring the use of AI technology to support more detailed performance feedback and identify key learning from each session. We recognise that there are practical constraints to the implementation of immersive technology, for example, cost and requirement for additional time and resources. However, we also know that immersive approaches are highly scalable across healthcare settings. For example, our immersive suite could with ease replicate the clinical environment at any other NHS trust. With that in mind, we're keen to share our immersive training space regionally. Any income generated from this could help sustain the resource through ongoing maintenance and upgrades. And finally, a question. With so much variation in how simulation training is delivered, in the future, could we see immersive simulation as a benchmark for excellence in maternity simulation training? And could this support the delivery of the safest possible care for women and babies? Thank you.